Hi, my name is Dr. Devang Desai. I'm a urologist here at St. Vincent's Hospital, and I'm here to talk about the management aspects of benign prostatic hypertrophy. The outline of my talk today is going to be looking at the natural history and the assessment and management of benign prostatic hypertrophy. I will also touch bases on what the newer technologies that we can offer here in respect to its treatment. The prostate gland is a small but important part of the male reproductive system. The prostatic enlargement can be non-cancerous and result in a lot of urinary troubles for these men. What we do know from the literature that a lot of men starting from as early as age 40 might suffer from benign prostatic hypertrophy. 50% of men from the age of 40 and up to 80% of men at the age of 80 will have troubles from their prostate. Prostatic hypertrophy essentially is a quality of life issue, and a lot of men are suffering quietly in the background where we have more to offer and more can be done so that we can alleviate some of these symptoms. The prostate essentially is made up of two parts. One is a non-cancerous part and one is a cancerous part. The non-cancerous part by far is the most common presentation that men come with and have symptoms from it. Prostate enlargement can be multifactorial. It is genetic, it is age-related, and it is due to the diet we have, which includes a high quantity of fatty foods. When the prostate enlarges, it blocks off the stream of urine, which subsequently causes a back pressure changes in the bladder and subsequently upstream up to the kidney, eventually resulting in renal impairment and renal failure. The question is, does all BPH require treatment? The answer is no. Not all of them will require pharmacological or surgical intervention. A lot can be managed with the lifestyle changes. So who do we think will actually require further treatment as far as pharmacology or intervention is concerned? Prostates which are larger than 30 cc in size, those who've got a higher PSA value, men greater than 65 years of age, a poor flow rate and a high residual volume are all predictors for requiring further intervention. The one single most aspect for the patient is the degree of bother. If you are bothered with your urinary symptoms, you're more likely to require treatment from it. The degree of bother for the patients is the best predictor for the outcome of surgery. Now, how do we assess benign prostatic hypertrophy? We have an international scoring system called the International Prostate Scoring System or the American Urology Association scoring system, which outlines both obstructive and voiding factors which we can assess on a score from 0 to 35 and address the issue of mild, moderate or severe symptoms from prostatic enlargement. Added to this would be a quality of life score and also an erection score, which will tee up into the pharmacological and surgical managements, and we can predict how these will affect a patient's symptoms. A basic examination would be involving an examination of the prostate and the external genitalia. Along with that, at our disposal, we've got a uroflow meter and a bladder scan, which we can assess the flow rates of patients to predict the outcomes. Lab-based tests such as urine microscopy and culture and a radiological investigation such as an ultrasound evaluates the size and shape of the prostate, for which we can offer more targeted therapies. Other investigations in patients who've got more than the stock standard symptoms may include a cystoscopy and urodynamics. Like I discussed earlier, the management of benign prostatic hypertrophy does not always require pharmacological or surgical intervention. Lifestyle changes are more than sufficient to manage the mild to non-bothersome lower urinary tract symptoms, such as reduction of coffee intake, tea intake, alcohol intake, and fluid management in itself. The moderate to severe symptoms may require further management such as pharmacological and surgical intervention. There's a lot of non-prescription based pharmacological treatment which has been widely used and accepted by patients. Nonetheless, none of these have had any scientific basis to predict the outcomes. We would recommend seeing a specialist in regards to these so that patients can have appropriate treatments given which will actually make a difference to their symptoms. Pharmacological treatments include alpha blockers. Traditionally, we've used alpha blockers which are non-specific and hence patients have had a lot of symptoms. Now we are lucky enough to have quite specific and selective alpha-1 antagonists which can help reduce the side effects for these patients and in fact give much better symptom control. Medical therapy includes the use of selective alpha-1 antagonists such as tamsulosin or silodosin. These drugs act by relaxing the smooth muscle fibers around the prostate and alleviate the urinary symptoms. These drugs do not prevent the risk of progression or the risk of retention in these patients. The common side effects of these drugs can be postural hypotension and retrograde ejaculation, which have to be addressed and have to be explained to the patient so that there are no other drug interactions such as beta blockers which they might be on. There are other drugs which can be used such as dutasteride. This is a combination drug and improves urinary symptoms by not only relaxing the smooth muscle fibers around the prostate but by also reducing the sheer size of the prostate in due time. These drugs, additional to the ones previously described, also have the side effects of erectile dysfunction, and that might be permanent. In my practice, I use them in patients who are not concerned or willing to give up their erections in treatment for their urinary symptoms. To make note that dutasteride also reduces the level of PSA and halves itself by about 6 months' time. This is in regards to patients whose PSA needs to be monitored if they have a potential coexistent risk of prostate cancer. Those failing medical therapy or progressing on medical therapy or not being able to accept the side effects from medical therapy would then be offered surgical therapy. We now have a wide range of surgical therapies to choose from, right from the minimally invasive therapy to the maximally invasive therapy, depending upon the size, the shape of the prostate, and the patient's symptoms. Minimally invasive therapy that we can offer are both Urolift and resume therapy, which is the water vapor therapy. Both of these are able to be provided through St. Vincent's Hospital. The idea about using minimally invasive therapy is to preserve the sexual function for patients and also at the same time improve their urinary symptoms. The Urolift is a mechanical device which pretty much is applied to the two lateral lobes of the prostate and pulls the prostate across like opening the curtains and allows patients to pass urine through the urethra. One of the other minimally invasive treatments which we have recently introduced in St. Vincent's Hospital is the resume or the water vapor therapy. In this, heated up steam is instilled into the prostate, which over a period of the next couple of months reduces the size of prostate and alleviates the patient's symptoms. With both this minimally invasive treatment, the idea is to get rid of the excessive prostatic tissue and to improve patients' urinary flow without adversely affecting their sexual function. Patients who may not be suitable or whose prostates may not be suitable for this minimally invasive treatment are still able to avail the traditional treatment, which includes a TURP surgery or a green light laser surgery. A green light laser surgery has the advantage of being able to treat patients who are on complex anticoagulation. Finally, those patients whose prostates are very, very large and unable to have any sort of endoscopic treatment can avail open surgery or robotic surgery to remove their excessive prostatic tissue. BPH is an evolving space and more therapies are being investigated as we speak, and we will hopefully see more and more of these in clinical practice in the near future. We at St. Vincent's are more than happy to provide the best therapies possible to our patients to reduce their symptoms and to improve the outcomes. I would like to take this opportunity to thank each and every one of you for listening to my talk, and I'm more than happy to be contacted.